So, very warm welcome to you all. I'm Rebecca Breslin, and I'm the SCAD Trustee Chair. And I'm joined tonight with Sarah Coombs, who's my fellow trustee, and also with Karen Rockall. So Karen's my fellow founding member of SCAD, and she was a trustee for 7 years. And she still helps us with a lot of projects such as this with our links into the FMD community. So, you know, at SCAD, we're really delighted to host this event. Now, FMD is a really important topic for the SCAD community. Up to 45% of SCAD patients go on to receive a diagnosis of FMD. You know, and it's an area that requires much more research as well, just as SCAD. So we're learning more all the time. We're seeing how these conditions are associated, and we're really interested to hear from our speakers today. So very warm welcome to all of you, our audience. We've got a mix of SCAD patients here who do have FMD, some patients who are perhaps still waiting for results of scans that they've had to find out if they have FMD. You know, and we've also got some FMD patients who don't have SCAD. So we've got fellow patients here. So we've got Kathleen across from the Belgian support group. So welcome, Kathleen and colleagues. And then we've got our healthcare professionals who are working in the field. So I think we're in store for a really good evening. So I'm going to hand over now to Karen, and she's going to introduce our speakers.
Thanks, Bex. It's really lovely to see everybody here. Very exciting evening. I'm just going to briefly summarise the agenda, and then I'm going to hand it over to the professionals. So there's going to be an overview of FMD for those that are new to this condition. It will be very useful. And then some discussion about what's new in FMD. And the understanding is growing all the time, and that's what's really exciting, is that things are moving on. We're then going to have an interesting explanation about the UK FMD Research Registry, and then we've got a pre-recorded video with Dr David Adlam discussing SCAD and FMD. Unfortunately, he couldn't be here tonight because he's up in Edinburgh undertaking an experiment, which sounds very interesting. So he sends his apologies, but we did record a Q&A with him last week, so that will be shown later. And then at the end, we're going to have a panel discussion with all of our health professionals here. And so if people, as Beck said, put their questions into the chat, then Sarah and myself will be looking at those, and we'll have an opportunity at the end to ask those questions and have a little bit of a discussion around the things that really concern us as patients. So with that, I will introduce you to Dr Tina Chrysochou, who is our FMD expert who's leading the evening, and welcome, Tina.
Thank you, Karen, and thank you to Bex, and thank you to everybody. It is such a pleasure to be here, and I'm really grateful to the SCAD group and FMD group for putting this evening on. You're such a vibrant community. It's an absolute pleasure to be working with you. So we've got a great evening lined up, as already discussed, but we're going to start first off with my colleague, Dr Aine De Bhailis. So let me introduce Aine. Aine is one of my consultant nephrology colleagues at Salford Royal Hospital. She started out as a clinical fellow doing a part of her MD thesis in Fybromuscular Dysplasia. So she's going to start us off with a bit of an intro into FMD along with what's new. Aine, I will hand over to you.
Thank you, Tina, and thanks for that kind introduction. So the first challenge will be to share my slides accordingly. So let me just find that now. Can everyone see my slides?
Yep, they're showing.
Perfect. So we're all here to discuss fibromuscular dysplasia, and for the rest of the talk, I will refer to it as FMD. So a brief outline of my talk. So we're just going to talk briefly about what is FMD, the types of FMD that we see, the symptoms and presentations of FMD, how we diagnose FMD, and also how we manage FMD. And finally, I'll speak just about some of the recent updates in FMD. So first of all, what is FMD? So it's a non-atherosclerotic arterial disease. Excuse me one second. That is characterized by abnormal cellular proliferation and distorted architecture of the arterial wall. So that's the medical definition of FMD, but it is an abnormality of the blood vessels that affects up to about 5% of the US population. These changes causes narrowing and weakness in the vessel walls that can predispose to blockages of the arteries, tears that we refer to as dissections, or the vessels to bulge out or balloon out in manifestations that we call aneurysms. There are two types of FMD. So there's the beaded or the multifocal, and there's focal FMD. And these can affect small or medium-sized vessels. And recently, there's been some changes in the clinical phenotype to also include dissection, aneurysms, and tortuosities of the vessels. So as I mentioned, there are two types of FMD. There's the multifocal FMD, which is the stereotypical string of beads manifestation that's seen on imaging such as angiograms. So here on the left, you see what we call the multifocal FMD, or the stereotypical string of beads, which is dilatations and narrowing of the blood vessels that presents in this way on imaging. So here on the left, you see two images of the renal artery on an angiogram, and you see that stereotypical string of beads, or pearl necklace type manifestation of FMD. On the right, you see the focal FMD, which is a narrowing of the blood vessel. And here you see on the right an angiogram, again of the renal artery, and you see a small little pinch on image A, or a narrowing that we call a stenosis. This type of FMD typically presents in younger women and manifests as ischemia or lack of blood supply to the organ distal to the narrowing. So there's various different manifestations of FMD within the arteries. So the stereotypical ones are the string of beads, or the focal FMD, which involves a specific narrowing of the blood vessel. You need one of these two manifestations for the diagnosis of FMD, but we're also seeing other manifestations of FMD in the arteries that can be found in various other vascular conditions. So we see dissections, which are tears along the vessel wall. We see ectasia, which is a generalized dilatation of the vessel, aneurysms whereby certain parts of the vessel balloon out, and tortuosity, which means that there's bends and twists in the vessel, causing this characteristic S curve, which we see on angiograms. In the bottom right corner, you see this is an angiogram of your internal carotid artery, which is the main blood vessel supplying your brain. And again, you see this twist and turn in the vessel on the angiogram, which is stereotypical of this S curve that we refer to on angiograms. So, as I mentioned previously, FMD can manifest in any arterial bed, but the vessels most commonly affected are your renal vessels, your internal carotid, and thereafter you can get it in your vertebral arteries, your visceral arteries, and your external iliac artery, which is the main blood supply to your lower limb. FMD patients stereotypically and more commonly have renal involvement at about 80%. 75% of patients can have extracranial artery involvement, so the blood vessels going into your brain, like your carotid vessels or your vertebral vessels in the back of your brain. 2/3 of patients will have involvement in more than one arterial bed. How does FMD present itself? So FMD, the disease manifestations results from how the FMD is affecting the vessel. So it can lead to ischemia as a result of the tightness or the narrowing that we previously mentioned in terms of stenosis. You can get a dissection, or an occlusion or blockage of a major artery, which will manifest itself as a stroke if it's affecting the blood vessels to the brain, or a heart attack, or what we call myocardial infarction, if it's affecting the coronary arteries. You can have a rupture of an aneurysm, or that ballooning out of the vessel. You can also get embolization of a clot that's formed at an area of abnormality, and that parts of that clot, or what we call thrombi, can then move towards smaller caliber vessels and cause a blockage. So there are various different types of signs and symptoms of FMD, and these are based on large registry data in terms of how frequently it is to get some of these presenting signs and symptoms. In general, males tend to have are more likely to have a renal manifestation of FMD, such as flank pain or hypertension, and women are more likely to have some cerebral manifestations of FMD, such as the headaches or the pulsatile tinnitus. These are the most frequent presenting signs and symptoms that we see in clinical practice. So hypertension, particularly if you have a narrowing of a renal artery, headache if you have one of the manifestations of your cerebral vessels, pulsatile tinnitus and dizziness is again is associated with cervical manifestations of FMD or the vessels going into your brain. Cervical bruit is a sign that we find on clinical examination when we put a stethoscope to the patient's neck and we hear the turbulent flow that's caused by a narrowing in one of the blood vessels. Patients can also manifest with flank or abdominal pain, aneurysms, or cervical artery dissections. So about 0.4% of patients with hypertension will be found to have FMD. This is more, the percentage increases in young children. 10% of whom will have FMD or another vascular abnormality such as middle aortic syndrome, which is a narrowing of your thoracic or your abdominal aorta. If we look at large trials that have been done for other reasons, so looking at kidney donors or looking at the CORAL trial, was this trial looking at the benefit of renal artery stenting in someone who has a tight renal artery for atherosclerotic disease. The incidence goes up to about 6% of all patients enrolled in those trials. And again, depending on what cohort of patients you're looking at and what the imaging used to look at those patients, your prevalence can go up to anything to about a third of patients. The average age of diagnosis is 47. And again, this is based on registry data. How do we diagnose FMD? So typically it's diagnosed based on radiological findings. So there are a few different options in terms of radiology that we can use to diagnose FMD. There's a CT angiogram, an MRI angiogram, duplex ultrasound, or catheter angiography. So duplex ultrasound is not commonly used in the UK. It's more commonly used in the US, where they have a higher rate of patients and more expertise than based on a duplex ultrasound. So you need to have quite a big cohort of patients and significant expertise with duplex ultrasound. A CTA or an MRA is more commonly used here in the UK. A CTA is preferred because of the spatial resolution that you see with the CT angiogram, and also it helps discriminate from other types of vascular manifestations, particularly in the renal artery, where the narrowing can be as a result of atherosclerotic disease, so the disease that we typically see in older individuals with lots of vascular risk factors like high cholesterol, high blood pressure. So a CTA is preferred, but if a CTA is contraindicated for any reason, then an MRA is a suitable alternative. A catheter angiogram is a more invasive test whereby we are inserting a guide wire into the vessel and doing x-rays to have a proper look at the dye as it goes through that vessel. The benefit of a catheter angiogram is that as well as being diagnostic, you can also do an intervention during the catheter angiogram if you have a very severely diseased vessel as a result of your FMD. So typically a catheter angiogram is for patients who have a negative or some ambiguity on a CTA or an MRA, but you still have a very high clinical index of suspicion for FMD. And here on the right, you see some of the angiogram images that we see to diagnose FMD. And again, what you're seeing in these various different angiograms are areas of narrowing or tortuosity, so those bends and twists that we see to try and diagnose FMD. So finally, how is FMD managed? So the important thing to say is that FMD is not managed by one particular specialty. It is a multidisciplinary approach. So there are various different specialties involved in the care and the management of patients with FMD. So myself and Tina are nephrologists, but we also work along with our cardiology specialist, or hypertension specialist, neurology specialist, radiology, who are invaluable in terms of diagnosing this condition, stroke physicians, and vascular surgery. So how do we manage it? So thankfully, we now have the first international consensus on the diagnosis and management of FMD, so that we are all managing FMD in the same manner. And this allows us to characterize patients and to screen them effectively, so that the treatment doesn't differ whether you're here in Manchester or anywhere else in Europe or in the US. So management depends on 4 different approaches. The first is, where is the disease? Secondly is, how badly does it affect the vessel? Thirdly, what are the consequences of the FMD? So what are the manifestations that the patient has or is experiencing? And finally, risk reduction in terms of reducing the long-term risks for patients. So first of all, where is the disease? So it's important to note whether the symptoms are related to FMD or not. So for instance, if someone reports pulsatile tinnitus, then it's important to look at the cerebral vessels in detail and ensure that they have no cerebral manifestations of the FMD. If they don't, and they're still complaining of symptoms relating to a certain arterial bed, that may mean that you need further investigations or referral to a different specialty. So it's really important to do head to pelvic imaging with either a CT or an MRA, again, to see where the disease is there arterial manifestations elsewhere, and also to try and manage some of the patient's symptoms. Here on the right, you see a head-to-toe angiogram looking at both the cerebral vessels, the chest vessels, the pelvic vessels, and the vessels going into your legs. Secondly, is how badly does it affect the vessel? So if you have a focal narrowing or tightness or stenosis of the vessel, this can cause downstream effects, causing a lack of blood supply to whatever organ that vessel is supplying. So here on the right, you see a CT angiogram of, again, the renal arteries. So in image A, you see a very tight stenosis or narrowing of the renal artery that's impairing blood supply to the rest of the kidneys. What we do in this situation is what we call balloon angioplasty, which means that we go in with a catheter, insert a guide wire past the narrowing and inflate a balloon to try and expand that narrowing so that we get better blood supply to the organ distal to the stenosis. So in image B, you see that this is someone who is just after having a balloon angioplasty. So that narrowing has been overcome by the balloon, and now there's better blood supply to the kidney. One of the stereotypical manifestations of having a narrowing in your renal artery is having quite high blood pressure. And we know that in patients with renal FMD, if there is a tight stenosis and we balloon that up, that there is a very high cure rate for hypertension or their blood pressure, so that they can come off as medications if they are someone who's on several medications to try and control their hypertension. In very complex and severe cases, we might do surgery to try and overcome some of these manifestations in the artery. This is typically reserved for people with very complex disease who are not amenable to balloon angioplasty. Thirdly, we look at the consequences of FMD. So hypertension is one of the common manifestations of renal FMD, or having FMD affecting the renal artery. We don't know exactly what the ideal blood pressure is for someone with FMD, but we treat according to the American College of Cardiology guidelines in terms of hypertension, and we use ACE inhibitors or ARBs. So these are agents such as ramipril, prindopril, irbesartan, or valsartan. And we go by the guidelines to try and get patients' blood pressure under control. Then cerebral manifestations such as headaches and pulsatile tinnitus, most of these are based on symptom control. You can use some medications that you would stereotypically use for migraines. There are some migraine medications that you would try and avoid in patients with FMD. So medications that cause vasoconstriction or tightening of the vessel that may be commonly used in migraines, which would be recommended to be avoided in patients with cerebral manifestations of FMD. With someone with tinnitus, it can be very distressing. So there are various different therapies that we can refer to for patients with pulsatile tinnitus. You may also consider referring them to audiology or ENT specialists or ear, nose and throat specialists to do hearing assessments to ensure that their hearing is normal. If the patient has presented with an arterial dissection or an aneurysm, so a dissection is a tear on the vessel wall, or an aneurysm where the vessel has ballooned out and unfortunately ruptured, causing a bleed, you treat these patients as you would any other patient who presents with an arterial dissection or an aneurysm. So in the case of a stroke, these patients will be treated with thrombolysis, where you try and break down the clot that's causing the problem, or thrombectomy, where you go and try and retrieve the clot that's causing the problem. In the setting of aneurysms, depending on their size and their location, these will be coiled or clipped to prevent them from rupturing. In terms of risk reduction then, so there's no large trial looking at the use of aspirin specifically in the setting of FMD. But we know that patients can manifest with thrombi or thromboembolic events similar to other vascular abnormalities. So it's reasonable to use aspirin in patients who are both symptomatic and asymptomatic from FMD. However, this is individualized. That means that it is based on the patient's presentation and their own individual risk and benefit in terms of an antiplatelet agent. We know from large registry data that those who smoke have a higher incidence of vascular aneurysms and more adverse events from vascular events, and a higher rate of needing vascular procedures, like what I mentioned earlier in terms of angioplasty and surgery. So we recommend to anyone to stop smoking. We recommend an annual follow-up. So this would include a clinical assessment with whomever specialist is managing your disease. We recommend an assessment of your kidney function if you have a renal manifestation of FMD. And again, depending on where you are in your disease, whether you're at the start, we would recommend head-to-toe imaging, or if you have a certain vascular manifestation that requires annular or serial imaging, we would also recommend that. In general, we tell our patients to avoid fluoroquinolones due to the risk associated with dissections or tears in the vessel and aneurysm, that ballooning of the vessel. It's really important to educate patients on red flag symptoms, and these are typically symptoms that involve cerebral manifestations. So any change in your neurological status, such as change in your visual acuity or symptoms consistent with a TIA, or commonly referred to as a mini stroke, we would recommend that you seek urgent medical attention. And pregnancy. So there are some implications for pregnancy. We know from registry data as well that patients with FMD have a higher rate of pregnancy-related complications. This is mainly if you have a renal manifestation of FMD. So patients with FMD who become pregnant have a higher rate of pregnancy-associated complications such as blood pressure in pregnancy, preterm birth, and also preeclampsia. However, this comes from a paper whereby 96% of the patients did not actually know that they had renal FMD prior to their pregnancy. So it's important to take that into consideration, because if your FMD is managed before your pregnancy, there's no reason to think that you would not have a successful and a good outcome from your pregnancy. So finally, we'll just discuss briefly about what's new in FMD. So here in Salford, we have the FMD clinic, which has an associated MDT with it. So we have input from renal, neurology, radiology and interventional radiology. And although it's in its infancy, we have over 80 patients who have gone through the clinic with either FMD, FMD and SCAD, SCAD alone, or a mimic of FMD. So these are patients who will have a radiological abnormality that is suspicious for FMD, but on closer examination by our FMD team and discussion at the radiology MDT, they're deemed to have an alternative diagnosis. We also have the UK FMD study, which Tina will update us on later. We also have the European registry data, and we have the first international consensus guidelines in terms of the management and treatment of FMD. This helps us characterize patients with FMD, provide appropriate screening and management, and it ensures that we have improvement in outcomes of all patients with FMD. This only comes from collaboration from healthcare individuals interested in FMD, but most importantly, patients who are willing to give their time and to enroll in these large registry databases. We know from registry data in SCAD, for instance, that FMD is found to be closely related, and patients with SCAD, 45% of patients with SCAD will be found to have an FMD manifestation in one or more arterial beds. Bex has already referred to this in her opening, but this is really important in terms of how we manage our patients, how we screen our patients, and also this particular registry database, which included 373 patients, allowed us to find a link with a particular genetic variant, which will again help us going forward in terms of further management of these patients, but also to try and find a definitive genetic link. So this particular genetic variant, the COL5A1, is a genetic variant seen in Ehlers-Danlos, which is a connective tissue abnormality, which has similar vascular manifestations to FMD. So this variant has become a recurrent variant seen in patients with multifocal FMD, so that kind of string of bead appearance, and has also been shown to have a link with arterial dissections in patients with vascular abnormalities, but also with multifocal FMD. So this, again, is going to help us in the future in terms of screening our patients and trying to identify the patients who are high risk of these more severe manifestations of FMD. So in conclusion, we know that FMD is a rare condition, but there is increasing awareness of the condition, and certainly Tina will testify to this in terms of her referral rate to the clinic. It can manifest in any vascular bed, which is why the head-to-toe imaging is really important to look for manifestations elsewhere. We now have an international consensus guidelines in terms of how we treat and manage patients with FMD, which should help to improve outcomes, not just here in the UK, but globally. And really, all of these advances in our knowledge of FMD only comes from collaboration from various different centres across the world, but also most importantly, collaborations with those who are affected by the condition. So patients actively enrolling in registries, giving us their time and their expertise in terms of how the disease affects them. And that's everything from me. Gurum Hagav is the Irish for thank you. So thank you very much for giving me your time. And now I'll hand over to Tina to talk about our UK registry.
That's fantastic. Thank you so much, Anya. I can already see lots of questions, lots of excellent questions coming through the chat, but we'll save them all for the end. Okay, can everybody see my screen now as well?
Yep, all good.
Okay, lovely. So as mentioned, my name is Tina Chrysochou. For those of you who've joined late, I'm a consultant kidney doctor based at Salford Royal Hospital. And this particular photo was taken from the UK and Ireland's first patient information day on FMD that was held in Salford in 2019. So I'm glad to say that some of the faces are still the same. So unfortunately, if you go from the left, Martin Punter was one of the neurologists doing the clinic with me. He has since emigrated to New Zealand. The neurologist after him also emigrated to New Zealand. But I'm absolutely delighted to have Aparna, who's with us in the chat. I think you could see her photo as well. And she's our newest neurologist. And we are so grateful for her being here tonight and helping us with the clinic. I then have Reka and Amit Hewatka thereafter, who are two of my most favorite people in the world. They're the most fantastic neuroradiologists. And because Salford is well known as a tertiary and quaternary referral center for neurosciences, they have fantastic expertise in all neuroimaging. And then we've got Karen on the right, who's managed to squeeze in the corner there. So I'm also the principal investigator for the UK FMD study, which is what I'm going to talk to you about now. So let's just give a bit of a background on how we came here. So we have been very inspired by the success and the impact of the European and international, called the FAIRY, and American registries and initiatives. We very much were aware that research on FMD has lagged behind in the UK, and we wanted to join the fray. But the question really was how. We've had quite a few challenges in being able to join in as streamlined a manner as possible. Of course, you've had the issue with Brexit, which meant that there were a few more firewalls thrown up in terms of joining the European registry. A very quick one would be to join as a single centre. So, for example, one of the centres in Edinburgh tried to join individually to the European registry. But the concern with just a single centre approach means that you're not going to be able to access as many centres as you'd like, and it very much relies on goodwill and interest from a particular clinician with this interest. So we took the more difficult course and we decided to go for national collaboration. So this all started with trying to get presence in the renal rare disease registry. So FMD is still regarded as a rare disease, and because each centre is only going to have one or two, some not even any case of FMD, some patients are just managed in primary care, we really do need to collaborate. So we originally formed a specialist interest group under the umbrella of RADAR. So RADAR stands for the Renal Rare Disease Registry. And this was a multi-speciality group. So we had consultants from multiple specialities, and we also had patients in that group. The benefit of RADAR is that it is what you call portfolio adopted, which we'll talk about just now. This essentially means that there is research nursing time that is funded by sort of the national network to enable recruitment. So this originally seemed the best way to go. However, unfortunately, the data that you can collect with RADAR is very limited. And to be honest, it's minimal, and it is absolutely insufficient to make any progress with. The one benefit to RADAR is that if you are in RADAR, then you consent to be included or be informed about other studies. So it means that all the patients who are in RADAR can be contacted to participate in the UK FMD study. So this is just the outline of the UK and Ireland first patient information day that we had at Salford in 2019. And there was a fantastic attendance. This was well before the days of Teams and COVID and everything. So it was a good old-fashioned face-to-face meeting. And not only did we have great talks by experts in this area, but we also had Sally B, who I don't know if she's on this call tonight, but some of you may know her. She's a celebrity chef and a wellness coach, talking about her journey with FMD and SCAD. We also had Professor Adlam on that talk. But importantly, after the morning session, we had an afternoon breakout session. And this was very much our chance as clinicians to hear from you and to understand from the patient perspective what was important to you. If you had to draft your wish list right now in 2019 of what you would like or where you would like FMD to go in the UK, what would it look like? And we came up with a consensus of 4 sort of clinical priorities and some research priorities. The first point on the wish list was that patients wanted a dedicated FMD clinic, understandably, because there is such variable expertise and only specialist centres might see such cases. So they very much wanted a bespoke, dedicated FMD clinic. You wanted coordination of your care, because sometimes you'll have care in different hospitals, different trusts, different parts of the country. And, you know, for you to have to try and negotiate the NHS's quirks and hospital quirks is difficult enough, never mind managing an underlying condition. You also wanted acknowledgement and validation of this condition, because some people regard this as a silent disease. You look completely normal, fit and healthy, but there is a lot going underneath that. And it was important to get validation of this condition. And what was commonly described at this day was tiredness. So tiredness was a common concern, but doesn't seem to be as well described in the literature. So this was something highlighted. The research questions are still research questions we are trying to answer today. So of course there's a question, why is it more common in women? And you can see just by the participants on tonight's phone call that the majority are women. There's a question about genetics. Is there a genetic link? Is there a role of hormones? And I can see already all these questions have come up in the chat box. So we'll try and answer what we can later on. And then of course, access to all this research data, but in an understandable format, something that actually means something to you and you can do something with. So it was a very informative meeting. We very much, at least from myself, Anya and Aparna's perspective, and I think Abby's on the call as well, so I haven't mentioned you. Abby's a cardiologist in London. We very much value patients as partners in this journey. And we can see from the enormous success of other patient groups, how you've helped to inform and support that peer support that you offer other people with FMD is fantastic, but also the fact that you've helped to fund research is equally as fantastic. And I've just put some snapshots of some of the patient groups around here, both in the UK and abroad as well. And the FMD Society of UK and Ireland are also a member of Genetic Alliance, just to help expand the reach and the impact. So you said, we listened, and this is what we have done regarding the first point. There is an FMD specialist clinic at Salford Royal Hospital. Salford Royal Hospital is one of 4 hospitals in something called the Northern Care Alliance group. There's been a lot of rebranding. So if you see Northern Care Alliance everywhere, that's where that comes from. Okay. We are part of the Renal Vascular Disease Service. Now, what do I mean by that? We have a long-standing, more than 20-year specialist interest in renal vascular disease. That means diseases that affect the kidney arteries. And we have an international expert, Professor Kalra, who heads up our service. We have significant expertise, a number of PhDs and research that has come from our center. So it makes sense to be under that same umbrella with all that expertise. So the FMD clinic started officially in February 2020. We accept referrals all across England. I am personally happy to accept referrals from all across the UK. There have been some challenges, and again, we can talk about that later, but as long as I have a referral from a physician, we can register you and we can see, or rather speak to you, because we're doing everything on Teams at the moment still. So not on Teams, on a telephone consultation still. The clinic benefits from neurology, neuroradiology, interventional radiology, and renal input. We have 2 monthly multidisciplinary team meetings with our separate interventional radiology groups. And something which I didn't expect when I started out doing this clinic was just how many FMD mimics have actually come our way, which has been quite interesting. Frustrating for some, because, for example, some service users have just had an isolated aneurysm or just a dissection, and understandably it helps to know is that part of a syndrome or a spectrum, or just to label that. And we haven't always been able to classify that as FMD if we go by the strict FMD diagnostic criteria, which we have to do. So actually, I have been very surprised by how many FMD mimics have come and how much I've had to educate myself about all these FMD mimics and signpost to the relevant teams as relevant. The clinic has genuinely ballooned, and over the course of this week, there have been lots of discussions about capacity. So at the moment, there is about a 4-month waiting list, but understandably, I will do my best where possible to see patients sooner, but we do need more capacity to help see all the patients we are seeing. So ultimately, we will be publishing some of our data. This is just a snapshot that Anya has helped us to collect. And this data is probably just a reasonably contemporaneous. So we've had around 80 patients, and around 35 we've excluded FMD. Now, some of these patients we are still keeping under follow-up, and we will be including in the UK FMD registry, and I'll tell you why later. The mean age of diagnosis of our patients is around 42 years old, and that's the range that I've put there as well. 77% female, and surprisingly, and 66% have had the multifocal FMD. Around 66% of the patients have just got renal FMD, or not just, but have got renal involvement, sorry, and 46% have got neck involvement. And 40% are current or ex-smokers, and around 28% have either been on the oral contraceptive pill or hormone replacement therapy. I've listed just some of the conditions that we've also seen coming to our clinic, just out of interest. So let's get on to the good stuff now. So it has only taken about 3 years and a good couple of grey hairs, but I am so delighted to be able to finally say we have a UK registry. We're not allowed to call it a registry though, because again, for some various ethical reasons, so it's called the UK FMD Study. In practice, this is purely the UK arm of FAIRY, so the European International Registry. For many reasons, it makes absolute sense for us to all be collaborating. That way we can compare data, we can pool our information together. This is a collaborative, not a competitive process. So we very much wanted to already align with the well-established FAIRY registry. Salford Royal Hospital are the sponsor for this study, and we're the first centre that have gone live with recruitment. It officially only really went live this week. We had to put in a substantial amendment to allow for telephone or virtual consent, because a good proportion of the patients who come to the FMD clinic in Salford don't come from our catchment area. So we do need to have other means of keeping in contact, and that is often with telephone consults. So we wanted the same to apply and not limit the number of people who could be included in this study. I want to just give my heartfelt thanks at this stage to the British and Irish Hypertension Society, who gave us £5,000 to help with regards to data storage and some of the technical aspects of the study. I want to thank Anya, who's on the call today, for her invaluable support for the multiple iterations that we've had to bounce back and forwards to the ethics committee and helping to get the paperwork aligned and all the various additions up to date. Sincere thanks to Professor Alexandre Persu, who I'm sure all of you will know. He is a tour de force in the FMD world and the most collaborative individual, and has been absolutely pivotal in ensuring that FMD is given the platform it needs on the European and international stage. And of course, there are counterparts in the States as well. And I also lastly just want to thank Hannah and Fatima, who are from our NCA research team. Those of you whose centres are going to be onboarded will soon become very familiar with Hannah and Fatima, who just are helping to ensure that the research teams on your side know what to do. So the first set of invitations were sent out by post this week, and we will be onboarding centres in stages. So every centre can only be onboarded after a meeting that is between the research teams, and then we will arrange a separate meeting with Professor Chrysochou as well, who will just talk through the technicalities of how to use the online platform. But each additional centre requires another amendment to our ethics board. So we have to keep things manageable at the moment, and that's how we've gone about it. You may just want to know also who's included. We've again tried to be we've gone in ambitious, so we want to include everybody with FMD. So our study also includes children, and thank you to Karen and the rest of the FMD group for running our consent forms past young people, just to make sure the language is understandable by those service users. I've already said this bit already, but we're going to be uploading our information directly into the Ferry platform, and there are more than 50 items that fields that need to be completed. There is also a material transfer agreement between the labs. So this is not compulsory, but it is optional to give a serum and DNA sample, which we can store at Salford Royal, or your centres can store and post separately to Alexandra's team in Belgium and in Paris. We have got storage space in Salford though, so we can also collect everybody's serum and DNA and post it out in a larger batch. So all of this is brilliant news. I'm absolutely delighted. I'm so excited to be joining the fray. There is only just one small point to mention. This is more relevant for the research teams. This study is not portfolio adopted. What does that mean? It means that individual centres do not get funding from a national body for the nurses to input into the platform. So we are relying on our co-investigators and collaborators in these centres and the goodwill of the research team. We are hoping that because there aren't significant numbers from each centre, that your clinicians who have got a specialist interest in this will help us. I've got good feedback from all my co-collaborators, so I'd like to think this will go to plan. So coming soon to a centre near you, hopefully. As I've said, if you have at any point been seen at Salford by myself, just the fact that we've done a telephone consultation allows us to recruit you to the registry. But these are the other centres that will be onboarded in the course of the next few weeks, months. We've got Barts in London. I've just put these in alphabetical order. So Barts, we've got Birmingham, Chelsea and Westminster, Edinburgh, Epsom and St Heliers, Great Ormond Street in London, King's College London, Leicester, and Glasgow have asked to be part of the second tranche of onboarding. So that's everything from my side. I'm going to stop sharing now. Happy to take questions later. I think the plan is now to go straight into David Adlam's talk.
Thank you, Tina.
Hello, Dr. Adlam. Really lovely to see you. Thank you for joining us for the FMD information update. We have some questions specifically about SCAD and FMD, and we hope that you can answer them. And there will be questions that people will be putting in the chat, which, as this is a recorded discussion, we'll be sending those out to you afterwards, hopefully for you to respond. Thank you. So the first question, do you know how many SCAD patients in the UK also have FMD?
So I would probably just take a half a step back and talk about the relationship between SCAD and FMD, if you like. What we know is that a proportion of patients who have SCAD, that's spontaneous coronary artery dissection, and I'm guessing you'll have some patients who have FMD and not SCAD in your audience. So just to explain that that's a cause of heart attacks in some people. So a proportion of patients who have SCAD will have variations and abnormalities of the arteries elsewhere in the body. One of the types of abnormalities that's seen is looks very like what we've seen in other patients who have FMD, fibromuscular dysplasia. And that's where we see on the, usually on the imaging investigations, the MR or CT scan, that the artery looks like it has a series of dilations and narrowings in sequence. And people say that that looks like a string of beads. So that is one manifestation of the arterial variations and abnormalities that we see in SCAD patients. It's not the only one. Sometimes we see a focal narrowing. Sometimes, I'd say, just the point narrowing rather than the string of beads. Sometimes we see just dilation of the arteries. That can either be an aneurysm if it's very localized, or we sometimes call it ectasia if it's over a longer segment of the artery. So all these things have different names. But I think it's important to understand that the things that we see in patients who have SCAD, there's a spectrum of different things. So I almost prefer to call them SCAD-associated arteriopathies, meaning opathy, just something that's wrong with the artery, rather than calling them FMD. Because I think sometimes we can get confused that FMD is the string of beads, but so some patients will say, but I've got a little aneurysm or I've got a focal narrowing. Does that mean I've got FMD? Well, technically speaking, you haven't got a string of beads, but you've obviously got the same thing in that you've got an arterial variation or an abnormality in association with SCAD. So how common are these things? Well, it can be a bit confusing when you look at the medical literature, and that's partly because it depends on how hard you look and with what tools you look. So if you screen all patients who have SCAD from head to hip, and you look to see if you can find FMD or some of these other variations and abnormalities, it then depends on where, essentially what you're labeling as FMD, which is why I went back to describe those things, because I think sometimes there's a tendency to call any variation FMD. So if there's a bit of tortuosity, you might call it FMD. Tortuosity is just where the arteries are a bit more curly. So it all depends on exactly what people are using as their terms for FMD. If you look at these things blinded, and this is not some sort of violent way of doing image analysis, it's a way in which you introduce other scans, and you don't tell the person who's looking at the scan who's SCAD and who's a normal patient, and then you ask the question. It's probably at least a third of patients that have something in this area of abnormality in SCAD patients. It may be a little more if you use higher resolution imaging techniques. But again, if you think about when you're using the higher resolution imaging techniques, what you're tending to see is more subtle abnormalities. So this is why it's confusing. I think perhaps the more important question is what proportion of patients who have SCAD and have a SCAD-associated arteriopathy, including the thing that looks like FMD, what proportion of those patients have a problem that's related, that arises as a consequence of that? So some sort of vascular event, a stroke or a bleed or something, that you wouldn't want to have. And I think it's important to say to patients with SCAD that those things seem to be incredibly rare. So whatever these abnormalities are that we find in patients, actually bad things arising as a consequence of those findings seems to be very unusual in patients who present first with SCAD, as opposed to patients who present first with their FMD and maybe then subsequently have SCAD, but the FMD is the thing that they present with first. Patients whose first presentation is with SCAD, who have these things found on investigations and tests, bad things arising as a consequence of those things is uncommon. But we do sometimes find things that we need to keep an eye on, particularly those little aneurysms, where we, depending on how big they are and where they are and all of those kind of things, we might want to keep patients under surveillance. So, in summary, this is the long answer to your question. In summary, it's quite common to find something, but actually a lot of those somethings don't really make much difference to the patient. In terms of the important things that actually, we need to keep an eye on or do something about, those things are uncommon.
Thank you. I think that makes a lot of sense. And that sort of really leads me to a second question, which is for a lot of the SCAD patients from way back when we first started as a support group and we got involved in that early research, knowledge about FMD was a lot less than it is now. And so for a lot of us that were scanned back then in 2013, 14, we're wondering whether FMD was actually spotted at that time, or whether this is something perhaps that that we need to think about getting rescanned. What would you say about that?
Yes, so in SCAD research, and to some extent in FMD research and SCAD FMD as well, that kind of, there's three different entities. There are some things that we know and some things that, you know, we'd like to learn more about. From what we know at the moment, patients with FMD in the context of SCAD, so patients who've had SCAD and then are found to have FMD, as I've mentioned to you, the FMD that we find doesn't seem to cause patients problems on the whole. It's very uncommon for anything really to arise as a consequence of it. It's almost a marker of somebody who's had SCAD rather than a problem, if that makes sense. We don't at the moment recommend repeat imaging. That's because, again, the research that has been done suggests that these things don't change a great deal. However, there hasn't been a lot of research in FMD in the context of SCAD. So it's something that, you know, we are kind of actively planning to do, to actually invite back some of those very early patients, both that had normal scans to see if normal changes, but also those that had, you know, these variations and abnormalities that we've been talking about, to see if there is any change over time. My expectation is that there won't be, because again, what we see in these patients, and even those patients that we've come across who had their scans many, many years ago, you know, we are not seeing lots of these patients who are having vascular events. And yet we know, as I've said, that probably a third to a half of those patients have some variation or abnormality of the arteries. So as I've said, it seems to be uncommon in patients who present first with SCAD and then have something found, that thing causes a problem going on forwards.
Okay, thank you. That's helpful. So moving on to treatment and management, is it different for SCAD patients who then are also diagnosed with FMD? Or do all SCADs all get treated the same, regardless of whether they have FMD?
Yeah, so this is an area of uncertainty. And it's an area where there are some clinical trials that are just starting that may give us a bit more information over time. But this is going to take a while for us to answer as a, you know, as a patient clinical team, if you like. So at the moment, I do manage patients slightly differently in this context. So if patients have SCAD and don't have stents, so we say this is conservatively managed, and they don't have a big scar on the heart, so the heart's still doing pretty well, and they don't have a lot of abnormalities of the arteries elsewhere, particularly a lot of FMD, then we would often think about stopping the antiplatelet therapies. These are aspirin and aspirin-like drugs. In some patients who have more in the way of FMD, particularly in the head and neck arteries, these are patients that, in the context of things that we know about FMD, we would tend to have treated them with an aspirin-like drug over time. A lot of this is theoretical. It's not clinical trial based. It's not really been shown that doing that makes patients better, but it's something, if you like, that if the sort of consensus of people who look after patients like this, that we feel that that's perhaps the right thing to do. We'd love to be able to move forward from, if you like, you know, consensus of international brains of people looking after patients to actual data, to be able to say whether what I'm doing here in terms of antiplatelet treatments for patients who have SCAD and FMD and patients who have SCAD and don't have FMD is correct or not. Some of these clinical trials are beginning that will start to inform us about some of these questions, but you know, the sort of the answers are probably still some years away.
Can you tell us where those studies are being undertaken, just out of interest?
So there's a study that started in Spain under Professor Alfonso, and what they are doing is taking patients with SCAD and assigning them to a higher intensity antiplatelet treatment and a lower intensity antiplatelet treatment, and also they're doing a similar thing with beta blockers, so they're either prescribing or not prescribing it. So it's a clinical trial. It's a first try of a clinical trial, and I think they're doing incredibly well. So, you know, that's not going to answer all of the questions, but it's going to give a start. There's also another international grouping at the moment that is trying to sort of build a large international collaborative to answer a similar question. And again, sometimes it's worth having more than one clinical trial to build slightly different nuances and understanding about these questions. So these are things which are actively either started, as in the Spanish study, or seeking funding, as in the other international study that I mentioned.
Okay, well, that's really good news. We'll look forward to hearing more.
It's really good news that we're starting to dip our toe into clinical trials. That's what we need to do to be able to, you know, move from where we've been at with research in SCAD and FMD to actually data to us to be able to kind of make decisions rather than, you know, doing it on the basis of opinion.
Yes, well, I can understand that. So it leads on to another question that a lot of people ask, and that is, does having FMD increase the risk of having recurrent SCAD?
So I think there is some data to suggest that is the case. I think what we have to remember here, first of all, is that there are some things here that we are still learning about. So, for example, how common is recurrent SCAD? Now, we know that SCAD recurrences occur. And, you know, if we go back to the original, you know, those seminal works that were produced by our friends and colleagues at the Mayo Clinic and our friends and partners in Vancouver, who really began this process of trying to gather together patients with SCAD to understand more about those patients. If you look at those very early studies, you can get an impression that recurrent SCAD is perhaps more common than we now think it to be. Now, the reason for that is that in the early days, the SCADs that we were picking up were the ones that were really unequivocal, the ones that were kind of, oh my goodness, this is a SCAD, you know, and those patients perhaps had a more severe presentation. And maybe those types of patients were more likely to have a recurrence during follow-up. Also, I guess back then patients, you know, they were a bit more, potentially a bit more historical. So they might have had their SCAD a few years ago, so they've had longer in terms of follow-up as well. Recent data produced again by the Canadian group in Vancouver has suggested that recurrences, if you like, in a more sort of typical population of SCAD that's out there in the population, rather than those perhaps more selected patients that we were looking at first of all, maybe a little bit less common, maybe somewhere around 1% a year, something like that, of patients that has a recurrence, so 10% over 10 years. So we're still learning a bit about that. And in that context, I think we still have a way to go to be really clear on understanding what increases the risk of recurrence, what reduces the risk of recurrence, you know, both in terms of medical treatments and also markers. In terms of the does FMD increase my risk of recurrence question, I think it's also a little bit around how useful that is. So we're probably talking about a small risk. And if, and as I've said, there may be some uncertainty around this, but if FMD increases that risk, it's increasing it from a small amount to something that's still quite a small amount. You'll still be more likely not to have a recurrence than you will to have a recurrence of using. And so I think it's important to emphasize that, because otherwise, if you have SCAD and FMD, we've already said maybe nearly half of patients will. I don't want half of patients to be sitting, you know, worried that somehow their risk is very high. You know, there may be all sorts of things that slightly alter risk. But I think the most important message is that yes, SCAD recurrences can occur. It's important if you get those very typical symptoms, and it's usually unequivocal, that you go to a place of safety to be looked after, you know, just during that acute phase. So all of those things remain important, but equally, you don't want to be sitting waiting for a recurrence for 10 years, not to have one, and then you've wasted 10 years when you could have been, you know, out enjoying life. And so, yes, you know, recurrence is something to have in the back of your mind, somewhere way back here, so that you react appropriately in the event that it happens, but equally not to become so big that it dominates, you know, how you live life, if that makes sense. So I probably wouldn't be overly focused on that perspective. I think, you know, those kind of things are quite useful for us that are doing research, because they maybe just give us little hints as to how this thing works. But I'm not sure it's so useful at a patient perspective, because I think it just has the potential to make people more worried.
Okay, thank you. Yes, I understand that. So the next question is actually a bit about some of those people that had a SCAD, were diagnosed with FMD and told that they had an aneurysm. How concerned should, what is an exact, it would be really useful for you to explain what an aneurysm is. Is it the same but in different parts of the body, different arteries? And how concerned should SCAD patients be about being diagnosed with an aneurysm?
So probably around about 1 in 10 patients with SCAD will have an aneurysm somewhere. In terms of what it is, it's a localized dilation of the artery. So you get a normal segment, you get a little thing that looks like a sort of an area of dilation, a little swelling of the artery, and then goes back to a normal segment. And I mentioned the word ectasia earlier, just to explain that in case patients have that on their reports or letters. Ectasia tends to be where the artery is broader over a longer segment. So it's a sort of it's dilated, but over a longer segment rather than a very focal thing. So should I be worried about an aneurysm? Again, I come back to what I said at the very beginning, which is that in SCAD patients as a whole, whether they have FMD, whether they have aneurysms, whether they have dissections in other arteries, whether they have tortuous arteries, all of these different things that we sometimes find, the incidence or the number of patients that have vascular events seems to be very tiny indeed, regardless of all of those things. There are some patients who have aneurysms. I think it is uncommon, it's not zero, but it's uncommon for those aneurysms to be at the size at which we would be thinking about whether or not we should be doing something. So we find all sorts of things in SCAD because we're looking, some of them are very tiny. You know, they are a millimeter or a couple of millimeters or something like that. And those very tiny things are not so important. Sometimes we will find things which are bigger, and obviously how big it is depends on where it is. So if you've got a really big artery, and you know, it might be that it's, you know, let's say you've got an 8mm artery and it's got a focal dilation to 10mm. That's very different to if you've got a 1mm artery that's got a focal dilation to 10mm. Does that make sense? So again, the size depends a little bit on where you're looking at. But I think, again, my experience for the most part is that there are some of these aneurysms and dilations that we keep an eye on. And that's, if you like, my job or the job of your cardiologist locally, to keep an eye on things for you so that you don't need to worry about it, to do occasional bits of imaging to make sure that it doesn't change. I have to say that my experience is that these things don't seem to change a lot in the patients that, you know, we look after and we have under surveillance. So yes, we find those things. They are quite uncommonly of the size at which we're, we would be thinking about whether or not to do anything. But there are some that we want to keep an eye on. The other thing is, just occasionally we may find a distribution of things with the arteries that makes us just think about whether or not there could be another related condition going on. These are the connective tissue disorders that sometimes people talk about. So sometimes your doctor or we may say, look, okay, we've got a little, as well as your SCAD or whatever, maybe you've got an aneurysm here and a little dissection there, and just that's a little bit of an unusual combination. And we might, in that context, say, let's pop and see a geneticist. Again, I have to say that the yield seems to be very low. We already know that from the genetic studies, that the frequency of these genetic disorders in SCAD patients is very tiny, 3.5%. So, 96.5%. A bit of rapid maths, wasn't it? So again, if you like, it's for us to just help you through that process. If we think a referral is a good idea, then we'll do those things. But if you have an aneurysm, our experience is those things seem to remain very stable over time in SCAD patients. We don't see problems arising from them. It's incredibly uncommon for us to want to do anything about them. But we do, we want to look after you and make sure everything's okay. And so sometimes we might say, look, have a scan in a year or have a scan in 3 years just to check that things haven't changed.
Okay, thank you. That's really helpful, I think. I'm sure what you've said is going to generate other questions. And as I said at the beginning, we'll collate those questions and I'll be emailing you with them. So I'll be grateful if you could take a look at those and we can share some answers back in the group afterwards. Thank you very much for joining us.
No worries at all.
Really
sorry I can't join
it.
you in person this time, and I hope you have a lovely evening.
Yes.
Yeah, hope you have a lovely evening.
Thank you. That was the lovely Dr. Adlam. Now, we do have an awful lot of questions in the chat. So Sarah's been beavering away trying to group them into where there's been several questions along the same vein. And so, Sarah, are you ready?
I sure am.
And Tina, would you like to decide who should answer them amongst your panel of experts?
Not a problem.
Lovely. So just to give you guys a heads up, we've got a bunch of questions about FMD itself, what it is, who gets it, is it progressive, so on and so forth. Then we'll move on to some hopefully quick questions about medications, migraines and artificial hormones. And then we've got a question on exercise. And then we'll end up with questions about the regions, the clinics and the registry, if that sounds okay to you. So to start off with, Karen and Bex, if you wouldn't mind just keeping an eye on the chat in case anything else pops in while we're doing this. So I'm going to try and group these first questions together. So first of all, do we know how many people roughly may have been diagnosed with FMD in the UK, and also how many children?
Okay, I can probably start with that question because in all honesty, the answer is we don't really know because we don't have a UK registry. Centres will say that they've got a handful of cases. So some of the big centres, all those centres that are listed, the specialist ones, will all have a handful of cases between them. So it's quite difficult for me to give you a more honest and accurate answer. I'm hoping that our UK study will be able to give you a better answer.
Okay.
So it may help to know, I suppose, the US registry has got more than 2,000 patients and the European and international one has got more than 1,000 patients. So the American registry has certainly been recruiting for 10 years, if not more, and the European one around 10. So I guess that gives you some flavor of how many cases have come forward. Again, these will only just be from certain centers that are either more likely to encounter such patients or have a vested interest. So yes, I hope that helps to answer that.
There was a follow-up question from somebody who said, I'm a bit confused, is it rare or do 5% of people have it? And I think that's in reference to the comment on the slide about prevalence of incidentally discovered FMD. I think that was among healthy kidney donors. I know I've read that fact and I share that fact on the SCAD support page quite often. It's true, it was found in up to 6% of healthy kidney donors, wasn't it?
So yes, that's very true. And there are some patients who do come to my clinic who've been incidentally found. In general, people in whom it is an incidental diagnosis have Well, very little trouble from FMD in general, because it's either very mild, very benign, and it's just an incidental finding. So yes, so when you look at dedicated radiological imaging, you do encounter it a little bit more. As to whether how many of those are symptomatic, it will be a smaller percentage than that. Anya, I don't know if you perhaps want to add anything to that.
Yeah, no, exactly what Tina says. So it's unlikely for someone who's fit and well and healthy to have a CT angiogram or an MR angiogram. And the closest surrogate we have for that are the healthy people who come forward as donors. So they will have a CTA or an MRA as part of their workup to be a donor. So it's really hard to say for definite how many people have FMD. But the donor population is a nice surrogate in terms of healthy individuals.
I guess also the question thereafter is, can these individuals donate their kidneys? And that perhaps needs a whole separate discussion to it. But that's something we could perhaps do at one of the subsequent patient events. I can give you a little bit of a synopsis on what the literature has shown. And I've written a paper with Alexandra as a co-author on some guidelines for centres, bearing in mind all the evidence out there on which incidences are regarded as safer to donate your kidney and where we would say it's best to try and avoid.
Okay. So then there's 3 next questions are kind of connected as well. So I'll mention them all. Do you know, are people born with FMD or do they develop it? Firstly. Secondly, could FMD be progressive? So for example, patients perhaps excluded at some point, would they perhaps one day in the future meet the criteria for FMD? Perhaps if they see their symptoms progress, they might want to be rechecked. And then another question, which is kind of related, which was, do we think that possibly FMD might affect all medium-sized arteries in the body, but perhaps it's only really obvious or apparent in a few? So is it a sort of a wholly, would you expect it to be a wholly sort of systemic thing, even if the manifestation of it is only apparent in certain areas?
Okay, difficult questions. The first one mainly is the difficult one. So regarding at what age you develop it, or was it always there? Very hard to know. What we do know from registry data is in people who've got the unifocal, in other words, a more concentrated area of narrowing, they present earlier. So if you've got a unifocal narrowing, you're more likely to present with symptoms because of that, either because of lack of perfusion, in other words, blood flowing through that particular vessel, less blood supply, pain, etc. So we do know that they present younger. As to whether this is something that you've always had, it's difficult to know. So we certainly know that children who present tend to have a more aggressive course. So if the younger you are, the more sort of striking the features are, then often you've had a more sort of dramatic entry into the world of FMD. We are looking at follow-up studies, and as Dave Adlam alluded to as well, it's only the minority that will go on to have successive episodes of either dissection, aneurysm, expansion, needing intervention. There are certainly patients in whom that will happen. And why they have a slightly more aggressive course isn't entirely known, but what we do know is that people who are smokers, so whether you've ever been a smoker or you're a smoker now, are more likely to have, if I can call it, a more aggressive course. So it's certainly something that we try to encourage, because smoking will interfere with the health of your blood vessels. So that's probably the best way I can answer that question in terms of when do you develop it. We don't know for sure, but usually the younger you are, the more striking the features are noted to be. The second question was regarding is it in all vessels of the body? So from the international consensus guidelines recommend a once-off top to tail imaging so that we can specifically look which vessels are more affected than others. And when you look at those images, you can usually tell which blood vessels are affected in a way that might have any relevance to you. So from a macroscopic radiological presentation, you can usually tell which vessels are affected. However, there is some fascinating work coming out of a group in Italy, part of the Media study, and a group in, I think it's Pisa, specifically in Italy. And they have found that when you image the radial artery and neck artery, so radial arteries are the arteries in your wrist, as it were. So if I just sort of show you in myself here, okay, when they image the radial arteries of patients with FMD, they notice that the blood vessels have got something called a triple signal. You know, instead of having just sort of like a double signal, there seems to be this extra signal noted on an ultrasound scan. So of course, that leads you to the question of, well, does this mean that all the blood vessels might have some subtle changes? Why then some are more likely to manifest with ballooning aneurysms or narrowing stenoses isn't clear, but this is fascinating work. It also, to me, opens the door for perhaps screening patients with non-invasive methods in the future, or perhaps if you cannot undergo a CT scan or have claustrophobia and unable to go an MR scan, or whatever it might be. This might open the door for that. So this is fascinating, interesting work that's come out. Interestingly, some of the other work with genetic aberrations of blood vessels also show that you might have a slightly more thickened carotid, that's the neck arteries. So watch the space. I think this is something to still be proven. But in terms of what's practical and relevant for you is that unless your radiological imaging shows something specific, it is irrelevant whether there is FMD anywhere else. It's irrelevant. I don't know if perhaps if Aparna, my neurology colleague, or anyone else feels I've missed anything with that answer. I know it was a long-winded answer, sorry.
Yeah, Tina, I agree with you, because most of these patients, some of these patients can be asymptomatic totally, and sometimes there can be an incidental bruit heard and one of the carotid arteries, and thereby suspecting in a relatively young, healthy, people with a bruit incidental finding, and thereby suspecting, getting all the scans done and confirming the diagnosis of the FMD. So it's quite difficult to say who would develop these symptoms, and if you have a suspicion of having FMD, it's always better to get a head to toe kind of imaging to see the arteries affected, and thereby we know the extent and also the severity of the disease.
That's really fascinating, and I love the idea that one day we might be able to get ultrasounds of our wrists and have some sort of screening program. Wouldn't that be nice? There've been a few technical medical terms mentioned in the presentation this evening. So Tina, could you do a very quick plain English guide to a few symptoms, a few names, please, for me, just so that we've got it on record so people can listen back to it. So the first one is ischemia.
Okay, so ischemia refers to not enough oxygen getting to a particular organ. So that would be because there isn't necessarily enough blood flow. So a good way to explain that is if you've got a blockage of a blood vessel. So for example, if there's a blood clot within one of the vessels to the heart, anything that blood vessel is supplying, and there's anything downstream of that blood vessel, will suffer ischemia. So ischemia means not enough oxygen getting to that particular organ or part of the body.
Okay, then the next two are embolization and thrombi.
Yeah, so a thrombus is a blood clot, essentially. So you might have heard a deep vein thrombosis that they often talk about on flights and things like that. So thrombosis is just a generic term that there is a blood clot. So I feel like I'm hogging the stage here. Maybe Anya, do you perhaps want to answer a bit about embolization or embolus as well?
Yeah, so embolization is when something breaks off that clot and moves distally to another vessel. So like Tina said, if you have a deep vein thrombosis, which is a clot in your leg, the concern is that it might move to one of the bigger blood vessels in your chest, which we call a pulmonary embolus. So a clot affecting your pulmonary arteries or your lung arteries. So the similar phenomena you can see in the arteries, whereby if you have a clot formation, so where there's lots of platelets coming along, and because of the blood flow through the vessel, a little part of that blood clot can break off and move to smaller vessels, and instead of narrowing the vessel, because it's a smaller vessel, it'll clot it off or block it off completely.
Fantastic, thank you. And I think we just covered perfusion just now. I think that was flow, was that right, Tina?
That's
Yeah.
right. Yes, yes.
Fantastic. So moving on, you showed a diagram, Anya, I think, of a balloon angioplasty in a renal artery, in a kidney artery. Could you talk a tiny bit about that? How does it happen? Can it cause damage? Are patients generally awake when you have one? In the SCAD community, just as a little bit of background, you know, we've all got used to the idea that if a patient can be managed conservatively, i.e. medication only, that is often the ideal situation. That stents and bypass obviously are essential if somebody is unstable, but that if patients are clinically stable and can be managed conservatively, that's a good thing. So perhaps you could just explain a little bit about why somebody might need balloon angioplasty, how it happens, what it's like to be you know, given one of these treatments.
Of course. So similar to SCAD, FMD, we try and manage, and most of the patients are managed medically without the need of any sort of invasive intervention. However, if you have one of these focal narrowings, so the really tight narrowing, particularly going to your renal arteries, that can lead to very high blood pressure, which can be difficult to treat with just medication alone. So this is really a small cohort of patients where that renal artery is so tight that there's very little blood supply getting to the kidney, and the kidney responds by driving up your blood pressure, trying to get more blood supply. If we can't manage the blood pressure with medication, or if it's impacting your actual kidney function, then we do what we call a balloon angioplasty. So that involves threading a little guide wire up into that blood vessel, and that can be done either through your radial artery or through one of your femoral vessels. You are awake for the procedure, similar if you were to have an angiogram for a heart attack. You're given some sedation for the procedure, but you're not put asleep as you would be for a major surgery. So that guide wire goes up to the area of the narrowing, goes through the narrowing because it's very slim wire. And then when the wire is in there, it inflates a balloon to try and open up that narrowing. So in comparison to when you have a heart attack where there's a complete blockage of a vessel or a really tight narrowing of a coronary artery, they try and deploy a stent to keep that narrowing open. What we know in FMD is that because the vessels are a little bit more friable or a little bit more delicate, they don't deploy a stent because you're at higher risk of a tear or a dissection in the renal artery. So they put in a balloon to open up the narrowing and then take out the guide wire. And in majority of cases, that is enough to cure your hypertension. And very few patients need repeated angioplasties or balloons going into their artery, similar to what we see in SCAD. So it's a very small cohort of patients that will need it, and it's in an even smaller cohort of patients that will need it again.
That's really helpful. Thank you very much indeed. Slightly different question, but something particularly in the SCAD community that a number of people report back is that when they have their head-to-hip scan, quite a few people are found to have enlarged aortas, enlarged ascending aortas quite often. So are you aware of that generally in the FMD community, or is that something that's more SCAD community specific? I'm not sure it's a question you can really answer, but have you observed it even?
So we've observed it in only a tiny percentage of patients. So if anybody does have an enlarged aorta, this to me triggers subsequent referrals. So the first thing I would want is a cardiologist's opinion. It may be relevant in some people to do genetic testing for conditions that can affect the aorta, because there's a certain sort of percentage over when you've gone over that, it does trigger a referral to some genetic tests. But it is the minority in the FMD community.
Yeah, I agree with that, because FMD, it mainly affects the medium-sized arteries. So if something like an aorta is affected, I should look into some other secondary causes that might be causing aortic diseases, like more diseases affecting the large vessels, like a Takayasu arthritis or some kind of a vasculitis.
Okay, thank you. There was talk earlier on about red flag symptoms, which mean that a patient should seek urgent medical attention. I think it would be helpful just to go over those again. I know vision changes, mini stroke symptoms were mentioned. Is there anything else that people should be on the lookout for, in this area?
So I will again ask my colleagues to chip in here, but I think it depends which part of the body is affected. So if you've got any stroke type symptoms, the acronym FAST, there's quite a lot of advertising around that. That to me would be something that should trigger you to seek help. From the cardiac, the heart perspective, anything that's suspicious of a heart attack, so chest pain, often it can be sort of like a central crushing chest pain, sometimes even back pain related to your jaw, your neck, sweating, things like that should trigger help. From the kidney perspective, because the kidneys don't as such cause pain, if I can put it that way, the way that your kidneys warn you that something's going on is by pushing your blood pressure up. So if your blood pressure is particularly high, so that might manifest with a severe headache, which again would be part of the fast symptoms. But if you've got headaches that just aren't going away, that's something that should be checked. I think those are sort of the most general red flag symptoms. Is there anything else you would add to that?
Apart from that, anyone with a sudden onset of slurring of the speech or imbalance while walking, especially attacks here, that points to the posterior strokes because of the involvement of the vertebral artery, which is much more commonly affected in FMD patients. Whereas the blurring of the vision is much more commonly seen in the anterior circulations because of the carotid, which is again one more commonly affected artery in FMD patients.
Okay, well, that's a good list of things for people to look out for. As Dr. Adlam was saying, we don't want people to be worried all the time, but it's more, we like to talk about in the SCAD community, knowledge is power. So if you're aware of what might happen and you've got that tucked away at the back of your head, then if those things do start to happen in your life, then perhaps you can do something about that. Okay, that's really helpful. Thank you very much. So moving on.
If I can just add some support to that, Sarah, I think that it's only natural that the majority of the patients that I speak to, or that myself and Aparna will speak to, are hypervigilant and are anxious. So there is certain comfort in the fact that fortunately recurrences are extremely rare. So I think there is certainly comfort there. I appreciate if it's happened to you, you don't see that as rare, and perhaps that gives you no comfort at all. But please be assured that it is rare, and rather know about something than not know about it. And I think that's why we put so much emphasis on things like stopping smoking, high blood pressure management, just generally keeping fit and healthy, because all this does help.
Yeah, absolutely, 100%. And it's exactly the same in the SCAD community. So are there plans to further investigate genetics? Is there anything you can tell us about that? You shared some really fascinating insights in your presentation, but is there anything more you can tell us about what we might look forward to in the future?
Yeah, so there are certain groups that are already looking at this, and it's more challenging than you might imagine, but how they've tried to approach it. So there are fantastic groups in New York looking at some of this, as well as in Europe. And again, the genetic knowledge is advancing rapidly. It's really hard to sort of keep up with all the new tests and how you understand things. But some tests involve just doing the wider sort of like panel of tests in a group of patients' DNA and see what flags. And then you can sort of see, oh, there's signals that this particular gene seems to be flagging a bit more commonly than others. So that's often one line of query that then will lead to subsequent investigations. But in terms of what genetic research is taking place right now, the factor 1 gene is the way I can explain it best. And again, Dave Adlam has given a brilliant YouTube talk on just this in an accessible way. So this is a part within a gene that is a risk factor. Okay, and it's a risk factor that might predispose you to a high incidence of SCAD, to FMD, but also carotid artery dissections, migraines. This particular genetic variation, however, is very common in the general population. So there is a bit of fear at the moment that this test is not good enough to be a specific marker. So I have had requests come to say, can I not have this factor gene test? It's not available. It's only in the research realm. And that's very much where it is right now. It's giving us a clue that we need to follow that trail of investigation. But that is nonetheless interesting because this particular factor 1 gene risk allele, if I could put it that way, if you have got a particular type of variation in it, you might be prone to SCAD, etc. But conversely, if you've got this particular variant, it actually is seen as protective from atherosclerosis. Now, isn't that fascinating? So it means that if you have got this anomaly, you might be more prone to FMD, etc., but you're actually more protected from atherosclerosis, which is by far more common, by far more generalized, is part of the aging process. So that's a really interesting association.
Absolutely.
Also, sorry.
We do have a video, Dr. Adlam, talking about that. And when we will probably do a summary of what we've discussed tonight, and we'll make sure that video gets shared again. So it's a really good point to make, Tina. It's getting that perspective right, isn't it? Be aware, but try to control hypervigilance, because that doesn't help anybody.
Yes, no, very much so. And there is lots of other research going on. For example, there's work on something called proteomics, looking at proteins that break off into the urine. Can we pick up anything from there? There's studies in, for example, zebrafish. So there are both lab and clinical studies and work on blood and urine to see what information we can gain. So at the moment, the UK isn't doing that yet because we're still just trying to get a registry together with patients and a database. But the plan is that any serum or blood samples or DNA that we get, we will be sharing with the labs that have got the facilities and the know-how to analyze larger groups, that it's more meaningful.
Fantastic. So last very quick question about FMD. You mentioned in your presentation that tiredness was a common factor among FMD patients. We've had a question, have many FMD patients been diagnosed with something like chronic fatigue? Are you aware of that? Is that sort of higher than you'd expect to find in the normal population?
So because we have quite a high proportion of patients who've had many strokes or strokes, there is certainly post-stroke fatigue, which I'm sure Aparna can talk to us about. There are certainly patients who've got chronic fatigue syndrome. Again, I wouldn't say it's the majority of patients, but I have got patients with it, and it is very debilitating. It's also quite hard sometimes to seek expert help in that regard. There is also I would say a high proportion of patients with pulsatile tinnitus, that's like that whooshing sound by your ears. And we're very fortunate to have the Wishes website that we can signpost patients to. That is, again, peer support and a source of comfort there. Sorry, Aparna or Anya, is anything to add to the tiredness one from your side? You probably said more than me, Aparna.
Yeah, we look into a lot of patients in the general neurology clinics who present with a chronic fatigue syndrome and kind of a fibromyalgia syndrome, but I haven't seen any of these patients with associated FMD, but I do agree with the post-stroke fatigue, especially in young patients with the FMD. There can be association with the long-standing, fatigue because of the ongoing symptoms, especially with this irritating tinnitus kind of symptoms or chronic migraines causing these non-specific, chronic tiredness and conditions. But in general, chronic fibromyalgia syndromes, I haven't seen any specific association with FMD in general. Yeah.
Thank you. Thank you. Have you had many cases of FMD running in families? You know, this is a question the SCAD community asks a lot, and the general answer they get is that typically it's not a familial thing, though we do have a tiny number of brother pairs and sister pairs in our community. Do you see FMD running in families?
So the interesting thing is that the longer the registries go on for, the incidence continues to drop. So what started off as a sort of almost a 10% incidence of family history in the French registry has now subsequently dropped to around 4%. So my understanding is that it's around about the 4% mark in general in all registries. The important thing is to ask it. I think that's the important thing, is that you do need to ask, and then anybody who might have symptoms that are suspicious for FMD, it would help for them to be scanned, because I guess you can't conclusively say that there's a family history without that crucial imaging. Again, I have a handful of patients who have family members with that have either got some associated phenotype of FMD or might have had symptoms of stroke at a young age, high blood pressure, etc., but it does not turn out to be FMD. So I think the important thing is to ask it and to again follow that trail so that you can individualize the response for that person and their family.
Fantastic, thank you. I think and hope the next section will be much quicker. Medications, migraines and artificial hormones. Pain relief medications for FMD. Generally speaking, I think we're all mostly told that non-steroid or anti-inflammatories are not a good idea. Are they okay if you really need them for a very short period of time, or are they an absolute no-no?
No, sorry.
Yeah, please go.
Yeah, for the treatment of migraines, especially for the acute migraines, I don't think triptans or serotonin agonists is a good choice of drug in FMD patients, because they act on the receptors called serotonin receptors in the walls of the blood vessels, which can sometimes constrict the blood vessels, increasing the risk of strokes in these patients. So that's not a good idea to prescribe triptans as an acute treatment of the migraines in these patients. We have several, safer options, like a short course of NSAIDs like diclofenac or brufen is still a good idea if there is no renal involvement in these patients. And with respect to the chronic, the migraine prophylaxis, we have several group of, drugs to prevent if the migraine attacks or so burdened with like more than 4 to 5 episodes of acute migraines in a month, then probably we can put them on a chronic migraine prophylaxis with much safer drugs.
So there was a follow-on question specifically about migraine medicines. I'm not sure if I'm pronouncing it right, but bisotofen?
Bisotofen. So okay. That's again a serotonin agonist, which, as I mentioned, it acts on the receptors in the blood vessel walls, which constrict the blood vessels. So that's not a good idea to prescribe bisotofen, even as a shorter course. Yeah.
So a more general question is that if my GP or headache specialist is unsure about the best medication for me to use, who can I ask them to talk to? Is there a migraine specialist with FMD expertise?
I think usually they will send to the general neurology, pool neurology clinics as a referral, and thereby we see the clinic, the patient in the general neurology clinics. Initially, we start the treatment, and if someone remains refractory to the treatment, then only we do a referral to the headache specialty clinics. And we have several different newer options like CGRP receptor, antagonists, which are like a newer drug treatment for the migraine. So that will be decided if some patient fulfills the criteria for a refractory migraines, then they will be offered these kind of specialized, newer treatments in the headache specialties.
Thank you. There was a comment on one of the slides about avoiding fluoroquinolone, and could we have a little bit of information about what that is and why should it be avoided? And then there was a follow-up question, is hydroxychloroquine safe instead of fluoroquinolones?
So two totally different groups of medications. So fluoroquinolones are antibiotics, okay? And the common names that we will have in the UK will be things like ciprofloxacin, levofloxacin, and ofloxacin. So anything that ends in -acin is a fluoroquinolone. Common can be used to treat things like urinary tract infections, for example. So that's one of our standard questions in our clinic. Now, why we have chosen to suggest avoiding these antibiotics is not because there is a strong association between these antibiotics and FMD specifically, but there are studies which show that these fluoroquinolone antibiotics can degrade or have degradative effects on connective tissue. And they might be important in how aortic artery aneurysms are formed and can rupture. So whilst this is not specifically where the FMD might be, we just feel, until proven otherwise, it seems safest to avoid any antibiotic that is going to have a degrading effect on the connective tissue of blood vessels. So yes, so fortunately, they're not the most commonly used antibiotics, but it's something that I tend to do as a standard practice. I just say, just avoid until we know otherwise. Hydroxychloroquine is different. So hydroxychloroquine is an anti-malarial, but also a disease-modifying drug in things like rheumatoid arthritis, autoimmune conditions. Obviously, it's had some heightened profile because of COVID. So it's a different medication. I'm not aware of any research that has any implications on FMD and hydroxychloroquine. So unless it's something I don't know about, it's not something that's flagged at all to me.
Thank you. It wasn't one that I knew of either. Question on HRT now. Certainly in the past and still currently, people who are not so familiar, doctors who are not so familiar with FMD and SCAD, there are often conversations about not taking HRT because of the possible hormonal link that we, the connection that we're aware of. I know that Dr. Adlam is taking, and Dr. Al-Husseini are taking increasingly pragmatic views on the use of HRT, and it should be symptoms based. And if you've got terrible symptoms, then you need to treat those symptoms, because those symptoms in and of themselves can be difficult for the patient and can have serious consequences for the patient. It would be really useful and helpful to have an FMD expert's perspective on HRT as well, please.
I couldn't agree more, Sarah. I think the important thing to remember is that you are a person first and somebody with FMD or SCAD, whatever, second or the third, fourth, fifth down the list type thing. So it's very much, you've got to take a pragmatic approach because we don't have any evidence otherwise. So there's no firm evidence that contraception, IVF, hormone replacement therapy, or even pregnancy increase the development or progression of FMD specifically. So therefore, it is appreciably, FMD is more common in women. So there is research trying to understand, is this to do with estrogen and the receptors, etc. But we have to be pragmatic. It is a very individual decision, and it's something that we do discuss on an individual basis. I would support you take a pragmatic approach here.
Thank you. Exercise. I know, again, this is a very individualized topic, but could you give some general guidelines for people who have either head or neck related FMD or have FMD elsewhere in their body? Are there any general guidelines that you would recommend people follow?
Okay. I'll let Aparna go start with that one.
Yeah, maybe because the FMD is much more commonly, it affects the vertebral arteries, which pass through the the vertebrae, the cervical vertebrae. Maybe it's wise to avoid exercises which can hyperextend the neck, like stretching exercises or hyperextension of the neck to a greater extent, or something like chiropractic. Even that's contraindicated because most of the times they might cause dissection of these arteries, which are much more fragile, resulting in a posterior stroke. So maybe, yeah, that's one of the things suggested.
And Aparna, do you get asked a lot about going to the hairdressers, for example, because that means that somebody's neck will be potentially hyperextended for a while? Do you get questions along those lines?
Yeah, definitely. That would That's the reason we avoid particularly patients with a vertebral dissections, to avoid something which hyperextend the neck. For example, yoga postures, some of the yoga postures you do, there is a lot of hyperextension. That's usually we don't suggest people doing that.
And would you say that if somebody did not have FMD that was visible in their cerebral arteries, or would you say for all FMD patients?
If on the imaging, if there is no evidence of a cervicocranial FMD, then I think that doesn't hold good for them. So it's again, the pragmatic approach is the individual based. If someone doesn't have a cervicocranial, we cannot, stop them from doing these exercises. So, yeah.
Okay.
From the kidney side, that would be the same. So in fact, we very much encourage exercise, healthy living, and in all honesty, the vast majority of the FMD patients are health conscious, fit individuals. So actually, we very much do encourage exercise. You just have to be mindful if you're somebody who suffers with very high blood pressure about, intense weightlifting. So it's just better to ensure your blood pressure is controlled before doing anything, sort of the more excess end of exercise. But otherwise, actually, we would encourage it.
Super. Some very quick questions about the clinics and the regions. So we're talking about cross-border referrals, also whether there is FMD expertise now in Scotland, in Northern Ireland and in Wales. Should people be looking to get referred to clinics in these countries if they exist? Or should they be looking to get referred to you in Salford? What advice can you give there? Yeah.
So I'm happy to see anybody, is the bottom line. The issues are often just, as you say, the referrals. I'm going to throw a question back at you, because you mentioned that the Scottish SCAD patients have managed to find a loophole now to access care in England.
They have. That was via Dr. Adlam, and to be honest, all I know is that I think he did something behind the scenes, and it's now possible for them to be referred without a funding issue cropping up. So it might be an idea for you and he to have a chat about that.
Yes, okay, that sounds very promising. As long as I've got a referral letter, because we do our consultations by phone at the moment, it doesn't really matter to me where patients come from, and I certainly have spoken to some patients in Scotland. What I've done in Ireland, for example, there is Dr. Katrina Canning, who has an interest in FMD in Dublin. So I've referred patients to see her. Two of our co-collaborators, one in Edinburgh and one in Glasgow, are renal specialists, but with an interest in FMD. So I've signposted that way as well. So those are sort of the best contacts we've got if you're unable to access the Salford clinic. But I will speak to David and see what he's done.
That's great. This is an interesting one, and I know it crops up a lot in the SCAD community, that's for sure. How can I get a head-to-hip MRI scan if my cardiologist thinks I don't need one because I've got low blood pressure?
So the first thing is that you usually need two scans, because most hospitals can't do this in one setting. I know they can do them in some centers in the States, but you can't in the UK. So we tend to basically request neck up and neck down. It's sort of two separate scans. If your cardiologist won't do a scan, I don't see what the low blood pressure has to do with that, in all honesty. Having low blood pressure is not a reason not to have a scan.
Yeah, sorry to interrupt. I think that obviously there is not enough knowledge about and awareness about FMD, and I think a lot of medical practitioners' knowledge is based on renal FMD, which can result in high blood pressure. Therefore, if they've got a patient in front of them with low blood pressure, which an awful lot of SCAD patients are in that boat, sometimes we hear in the community that they tell me, I don't need this investigation because I've got low blood pressure. So is there an angle that as a patient we can push for? I mean, we've got a best practice leaflet for SCAD that we share, and we encourage our patients to share, show the doctor or the GP and ask them to follow best practice guidelines. Have you got anything else that you can suggest that we put in our arsenal for, for becoming better at advocating for our needs?
So the best thing is to get a referral to ourselves, because that's something that will then come as a direct request from us. And then patients can have that locally, but then the films will be transferred to us for assessment. So I would suggest that's something that we're certainly happy to help with. I'm just trying to think in terms of accessible information that you could signpost to. So there is something on the Radar website that we've uploaded that just signposts to the head-to-tail imaging. The British and Irish Hypertension Society also produced a statement. That was more to do with COVID, though, at the time of COVID. I'll need to double check if that covers the head-to-tail imaging. But yes, I think probably the most pragmatic is that either the GP or the specialist can refer to us for that question to be answered.
Fantastic. And one final question on that is, if my consultant wants some advice, do you have capacity to answer colleague questions?
Yes, that's fine. I find it's always easier to actually see the patients, or to at least get all their notes, that you can get a holistic picture and speak to them as well. But absolutely, we're all on the same side here. We need to work together.
Fantastic. Right. I'm very conscious that we've just past 9. We're on the last set of questions. There's just a few of them. It's all about the FMD registry. So hopefully people will give us a few more minutes to finish all this off. So can we be enrolled in both the SCAD registry and the FMD registry?
Yes, if you need to have FMD to be in the FMD registry. So whether you've got FMD and SCAD or without, you're eligible.
Fantastic. And the way that we enroll in the FMD registry, so for example, I'm now probably talking for the SCAD community, many of us got diagnosed with FMD at the same time as we got diagnosed with SCAD. Yeah. What should we do? How should we get our enrollment underway?
Okay, so the first thing is, if you're in one of the centres that enrolls, then they can enrol you. If not, and you've, as I said, been seen by Salford at any point, we can enrol you. If you are not in a centre that is part of the recruitment process, then that particular the clinicians with an interest, if they just get in touch with myself or Anya, we can put an amendment in to get their centre onboarded.
Okay. Okay. Is there a limit to how many people you're going to allow to join the FMD registry?
No, there's no limit, but all research has to have a shelf life. And essentially once there's more than 1,000 patients or 10 years, something like that is that right, Anya? That's what we've put, because you have to put an end date, and anything more, you just have to put another amendment. We're experts in amendments now, but yeah, as many as possible would be the ideal.
Right. Well, that's the end of the list of questions. I think I've been keeping an eye on the chat, but Bex and Karen, is there anything else that I've missed that you feel we need to ask here?
I don't think so.
No, there's nothing else that's come up that.
Well, I'd just like to thank everybody who sent questions in advance and on this evening. It's been really, really interesting looking at all these questions coming in. And I'm imagining they've given Tina, Aparna and Anya a lot to think about. And we're really grateful to you for the answers that you provided. So thank you very much. And thank you, Sarah, for doing such a brilliant job of compiling them and asking them. That's a really tough job. So I think you did brilliantly. So well done. And have a gin and tonic now. So really, I would just like to say thank you to all our health professionals for giving up a Friday evening to do this for us. We're really, really grateful to all of you, Tina, Aparna and Aine, and Abby came and went, but we were glad to see her briefly. I want to say thank you to Bex and Sarah particularly, because they've been so good about supporting the FMD group and helping to host this for us. So I really appreciate all the hard work they've put into putting this on as well. And finally, to say thank you to all of you for coming, because it wouldn't be any good if you weren't all here challenging us with all these questions. And hopefully we've answered a lot of them. We have recorded this so that in the next few weeks, the recordings will be available, and they'll be on both YouTube channels so that people have access to them.
And I will be sending the questions about SCAD if there are any. If there's any other questions anybody thinks of tonight or tomorrow morning or whenever, they can always drop us a line. And I will be feeding back some of these questions to Dave as well, so to hear his view on those. And probably last thing to say is have a really good Friday night and weekend. And thank you, everybody.